And I'll focus on behaviors that lead people into the justice system and then what we can try to do to intervene with those behaviors. I have no conflicts of interest. So in the US, we incarcerate more people than a lot of other countries, most other countries. So we incarcerate about 700 people per 100,000. And what that looks like is almost 12 million people are entering the criminal justice system each year. So about 1 in 37 adults are under some form of correctional supervision at any given time. Come on in. So about 1 in 37 adults are under some form of correctional supervision at any given time, which means that they're either detained, they got arrested and they're detained, they're serving their sentence in a jail or prison, or they're out in the community under probation or parole. And it's easy to think of people in the justice system as being, kind of far away from us and never coming back, but we know that that's just not true. So 95% of all people who enter the justice system will eventually come back out into the community at some point. So what we know is that when people actually do re-enter the community after being incarcerated, they have a lot of trouble staying out of the legal system. So 68% of people are rearrested within 3 years of being released, and that number rises to 77% within 5 years. So you might be wondering, what does this have to do with clinical psychology or psychiatry or medicine in general? So we know that correctional facilities have become one of the largest providers of behavioral health care in the US. And in certain cities like LA, the jail is the largest provider of mental health and behavioral health care. So studies have found that up to 80% of people who are incarcerated have significant mental health or substance use symptoms. And these are general population inmates. So these are people who are not in a specific medical or serious mental illness unit. So there's a significant treatment need among this population. When you look at specifically at disorders, so diagnoses, you see that 63% of people have substance use disorders and 64% have mental health disorders. I'll separate those, even though they're all mental health disorders. I'll separate substance and mental health in this talk. When you look at co-occurring, the rates are even higher, so co-occurring substance and mental health. This is a problem because most people who are arrested report that they've never received any sort of behavioral health treatment in their life. So why is that a problem? Because people who have substance use symptoms and those with mental health symptoms are more likely to get rearrested. So people with mental health symptoms are more likely to have technical violations that lead them back into the justice system. People with substance use symptoms more likely to recidivate. So this problem is known as the revolving door, the U.S. prison system, because people tend to, once they go in, they tend to cycle throughout. So my research tries to tackle this problem. So I'm interested in taking what we know from the fields of clinical psychology, public health, and criminology, and trying to improve behavioral health among people in the justice system. And does anyone has worked with justice-involved populations at all, or interested in somewhat? Okay. So I take 3 different approaches to this problem. So first I try to identify what are the specific psychological and behavioral mechanisms, what are the malleable factors that we can try to intervene with that lead people to do illegal things and get arrested and get into the justice system, and also what makes it hard for them to adjust in their community post-release. Then I try to understand the role of sociocultural factors, particularly stigma, which has a huge impact on this population, and how that kind of intersects with psychological and behavioral mechanisms. And then I try to take that information and adapt evidence-based treatments in psychology for people in the justice system or for justice contexts. So I'll talk about those 3 things today. Before I get into those things, it's important that we're all on the same page about the criminal justice system. So has anyone seen this model before? Sam says, okay. So some people have. So this is called the sequential intercept model, which isn't an intuitive name at all, but it's really a useful model they developed to identify, to basically pinpoint different points in the justice system where you could intervene, because there's a lot of different points and they're all different. So the first one is you do something illegal and you get noticed by the police, so you get arrested, someone calls 911, that sort of thing. The second point is when you're initially detained in a correctional facility. So no matter if you kill someone, if you're just walking around drunk, like falling into a ditch, like everyone goes into jail initially and is detained there before they get sentenced. So then once you do get sentenced, you either go to jail or prison. If your sentence is less than 2 years, typically you'll stay and serve that in a jail setting. If it's more than 2 years, you might go to prison. And then the fourth intercept is referring to reentry in the community. So you're either leaving jail or prison, going back into your community. And the fifth intercept has to do with being under community supervision, which means that a parole or probation officer is still monitoring what you do. You might have an ankle bracelet, you might not. You're out in the community, but you still have to report to someone and often do urine drug screens and that sort of thing. So that's the justice system. So the first part of the talk, I'll tell you guys about 2 studies I've done that try to identify different populations, different psychiatric populations and how they end up in the justice system. The first one that was just published in Journal of Clinical Psychiatry has to do with psychiatric disorders and crime in the US. So here we are at our nice little model. We're talking about how people go into the justice system here. So the rationale behind this study was that there's been a lot of research showing that people in forensic settings, so either forensic hospitals or prison settings, people in those settings with more mental health symptoms are more likely to recidivate and stay in those settings. So we know that. But we don't have any population-based research in the US in the past 20, 30 years showing whether people in the community who have mental health and substance use symptoms, what their risk is for engaging in different types of criminal activity and getting involved in the justice system. So we don't have a good sense of, among people just living in the community in the US, what's their risk if they have a mental health disorder, if they have a substance use disorder, what is their risk of engaging in crime and getting arrested? So in order to look at this, I used data from the National Epidemiological Survey of Alcohol-Related Conditions, the NESARC data, which is published by NIAAA, really useful, huge data set, 36,000 US adults. They do lots of nice things so that it's a representative of the US population. It's a great public use data set if anyone ever wants to access it. So we looked at that data set and I used that because it has DSM-5 diagnoses, which the most current DSM that we're using. And then it also had a lot of questions that ask people about their criminal behavior, which you don't often see in data sets like that. So in this data set, they basically went around to people in the US. They did in-home surveys with adults and asked them about a lot of different things, but crime was one of them. So they asked about current legal problems. So they broke it down between substance-related and then just general legal problems, and then substance was further broken down into alcohol and drug-related legal problems. So the questions were, have you been arrested or had trouble with the law because of your drug use in the past year, because of your alcohol use in the past year? So it was self-report based on the person's perception, but that's what we got. The NESARC also had lifetime criminal behavior questions. So they asked adults whether they had done illegal things as an adult. So have you ever set something on fire, destroyed property, hit somebody, hit your partner, killed somebody, sexual offenses? They asked them about all different sorts of things. And then they asked if you've ever spent any time in jail or prison as an adult. So we had those 2 different types of criminal, or 5 different types actually. So we had 3 current measures of current legal problems and then 2 lifetime measures. And what we wanted to do with the study is see whether people with mental health disorders, substance use disorders, and co-occurring mental health and substance use disorders, see what their risk of engaging in these different types of crime is. So the first thing that we see in the results here is that among US adults in the past 5 years, we see that 28.5% said that they've engaged in some sort of antisocial criminal behavior. I don't know if that seems surprising to people or if it matches up with their own criminal behaviors they've done, but 28.5% of US adults say that they've done something illegal. 11.4% said that they've been incarcerated as an adult, which is higher than what I would have expected, because other studies a long time ago have shown that it's about 6%. So we see that current legal problems, about 1.8% of adults say they have general legal problems, not necessarily related to substance use. 0.8% said they had current in the past year alcohol-related legal problems, and then 2.7% said they had drug-related legal problems in the past year. So those are our outcomes. So the first question is, does the presence of any sort of disorder, so if you have a mental health or substance use disorder, does that increase your risk of engaging in criminal behavior and being involved in the justice system? And not surprisingly, we see that it does. So people with any disorder compared to people with no disorders are around 4 to 5 times more likely to report criminal behavior, incarceration, and then the current legal problems. And you can see that if you have a disorder, you're really, really likely to report alcohol-related legal problems. You're 12 times more likely to report those sorts of problems. So the second question is, okay, so we know that any disorder, you're more likely to engage in crime, to have these types of criminal involvement. So what's the deal? What type of disorders is it? So we broke it down by people who had only a mental health disorder, those who had only a substance use disorder, and then those who had co-occurring mental health and substance use disorders. And we see that across all of our outcomes here, people with the co-occurring mental health and substance use disorders had the highest rates. We see an exception for alcohol-related, that's being driven by substance use, but in general, people with co-occurring disorders were most at risk of engaging in all different types of crime. And then finally, we broke it down by type of disorder. We did a lot of other analyses for this paper as well, but these are just some of the analyses. So we looked at mood, PTSD, substance, anxiety, and then schizophrenia or psychotic disorders. And we see here that these effects, when all of these things are in the same model, predicting different outcomes, it's really substance use disorders that's driving these effects, though we do still see that the presence of mood and PTSD in particular still are associated with crime, even when you're accounting for substance use. But largely we see that substance use is really driving this effect here. And I didn't even include the substance use outcomes because the only disorders that predict those are substance use disorders when you include mental health and all types of mental health disorders in the model. So this study showed basically that the presence or co-occurrence of substance use, especially the co-occurrence of substance use and mental health disorders, really increases risk for both criminal behavior and all types of criminal involvement, including those that are related to substance use and those that aren't. So the next steps are really to identify, what types of substances most increase people's risk. Is there a difference between opioid use versus alcohol use? And then also trying to understand whether more community-based and prevention measures can mitigate this risk. So whether if there's a way to kind of access these people in the community before they get involved in the justice system, can that decrease some of their criminal involvement? And then another question that this study prompts is how much people in the community and just other sorts of systems are asking about criminal behavior, or how comfortable they are asking clients about that, or targeting that in their treatment. We know that we do it all the time in the justice system, but in other settings, that's not as clear. Okay, so now that we've seen that people with mental health, again, not super surprising, but updated prevalence rates, people with mental health and substance use disorders are more likely to engage in all sorts of crime and criminal involvement.
Excuse me.
Mm-hmm.
When you put it this way,
Yeah.
kind of cause and effect, we could also come to the conclusion that people with the criminal behavior can have more prone to be substance user and having a mental illness.
Mm-hmm.
So if you reverse the sentence, it could be true too in this situation.
Yeah, it could be. And the NESARC is not longitudinal, so it's cross-sectional. Yeah, so you can't draw any sort of conclusions about causality there. So it could very well be the other way around. There is a lot of interesting research right now, though, that compares, like for instance, with people with PTSD. It compares kind of how they were before and how they were after receiving that diagnosis, and looking at the risk and antisocial behaviors they engage in as a result of some of their symptom clusters, such as like being suspicious of everyone and now, punching someone if they come up behind you. So there are some interesting research kind of trying to draw out some of those mechanisms for how different groups might kind of get involved in the justice system. But yeah, it could be the other way around. But there's a lot of theory, I think, that would suggest this way. Okay, so now I will tell you guys about a study that I did looking at a specific psychiatric population, people with borderline personality disorder, and how those people get involved in the justice system. So again, we're still at the very first intercept here. Does anyone in here interact with people with borderline personality? Lots of people do. Do we like interacting with people with borderline personality? Yeah, we do. No? All right. I do. We can talk about that another time. Clinically, this is one of my favorite populations to work with in the context of a very structured treatment called dialectical behavior therapy. But so we probably all know people with BPD have very severe psychiatric symptoms. They have very severe emotion dysregulation. They often engage in impulsive, self-harming or other harming behaviors when they're emotionally distressed. They have a lot of crises, interpersonal crises, other crises, engage in lots of risky behaviors. They also have suicidal ideation and behaviors, as well as a whole bunch of other symptoms, fears of abandonment, emptiness, those sorts of things. So it's not surprising that people with these symptoms are highly overrepresented in the justice system. If you think about lots of emotion dysregulation and impulsive behavior, for me, those things seem to be kind of related to being involved in the justice system. So we do see that 15 to 43% of inmates have significant symptoms or diagnoses of BPD. So it's very highly prevalent in jails and prisons. And there's been a couple of community studies looking at BPD symptoms and their association with criminal behavior, so not charges or arrests or anything, but just engagement in criminal behavior. And you see that people who report more BPD symptoms also report more criminal behavior. So they are more likely to engage in shoplifting, disorderly conduct, assault, drug offenses, reckless driving, all sorts of things. So we see this relationship here, but we don't actually know why people with BPD wind up in the justice system. We don't know the mechanism explaining that relationship. So in this study, I wanted to look at two different mechanisms that might explain how this population becomes involved in the justice system. The first one, kind of like I already alluded to, if people are experiencing really intense emotions and emotional distress, sometimes they do things that are impulsive, and sometimes those things might be illegal. So maybe it's that people with BPD are really distressed and doing illegal things, and that's how they wind up in the justice system. So that's one proposed mechanism. So the second has to do with physical aggression. So people with BPD have very intense anger and difficulty controlling their anger. So it may just be that they're engaging in a lot of aggressive behaviors. Maybe they're assaulting people more, and that's how they're winding up in the justice system. So I wanted to test these two different mechanisms. And I did this when I was doing my clinical internship in Mississippi at the University of Mississippi Medical Center. I worked a lot with people with BPD in the context of a dialectical behavior therapy clinic. But this population that we drew from actually was substance users who had completed measures of BPD symptoms, because BPD often co-occurred in this population. So we had measures of their BPD symptom severity, we had measures of emotion dysregulation, and in particular, the engagement in impulsive behavior when experiencing emotional distress. We had measures of physical aggression, and then two types of crime outcomes. So the first one was, how many charges have you gotten in your lifetime for a lot of different things? So that could be, you have 15 charges, they're all drug possession. Then we looked at the number of different types of charges. So you could have 15 drug possession charges, but then you could also have 15 charges where a couple are drug possession, a couple are sexual assault, maybe you did arson, maybe you stole from someone. So they're getting at two different types of criminal outcomes there. And then we looked at these in a model to see whether there's any support for these mechanisms. So what we found is that among people who were in a substance use treatment facility, those with more BPD symptoms were more likely to report physical aggression and emotion dysregulation. But the only mechanism that explained criminal charges was emotion dysregulation. So we can see this indirect effect here is significant, which suggests that people with high BPD symptoms who engage in impulsive behaviors when they're upset or distressed, that can explain how they are having a lot of charges, criminal charges in their lifetime. So this really identifies emotion dysregulation as a potential point of intervention for this population. And we see them so often in the justice system, and even in other settings, we could target this to kind of prevent justice system involvement. So that's some work I've done around trying to identify how different psychiatric populations become involved in the justice system and the mechanisms explaining that. And the second part of the talk I'll tell you guys about is some work I've done around sociocultural factors, and in particular stigma. So when I was a graduate student, I received a grant to examine basically how stigma impacts jail inmates in terms of their functioning after they get released from jail. So that is what I will talk about today. So stigma is any sort of socially devalued characteristic in our society. So you can think of probably a lot of examples of things that are socially devalued. These are just a few. Having a chronic medical condition, having a mental illness, a substance use problem, physical disability, a criminal record. So these are all conditions that are they're not valued in our society. And what I'll argue today is that people who have these sorts of conditions, and a lot of research supports this as well, have a much harder time. It affects their emotions, their behavior, and their adjustment. So people in stigmatized groups are subject to factors that can affect their behavior in important ways. So how does stigma impact behavior? There are 3 different ways that it can impact you. So the first one is structural factors. So if you think about people with a criminal record, there are laws in place that actually serve to kind of, there are laws in place that marginalize them from participating in the community. So for instance, in certain states, if you have a felony, you're permanently banned from voting. In other states, it's only temporary, but that depends on what state you're in. I don't actually know what it is for Tennessee. I just moved here. But so those are the structural factors. That's an example of how stigma can impact you. There are social factors for how stigma can impact you. So people with a criminal record encounter others in their community, encounter their treatment providers, their doctors, employers. So these are the attitudes and the behaviors that community members engage in that make stigmatized groups feel uncomfortable or unwanted or excluded in some way. So the last way that stigma can impact behavior is by how the individual person responds to these other factors. Some stigmatized people are resilient and they're not affected by these other factors. Other ones are really affected by these sorts of factors. So there's individual variability here, and that's where most of my research has focused on, is how the stigmatized people themselves respond to these factors. So the first study that I'll tell you about has to do with how stigma impacts behavior among people with a criminal record. So we're actually jumping forward in our criminal justice system here. So we were at the beginning, now we're jumping to reentry because the work that I've done in the justice system, I found that stigma is most kind of salient and on people's minds as they're leaving the system and reentering the community when they're about to interact with community members again. So there are a lot of different ways that people in stigmatized groups can actually deal with stigma. There's a lot of different measures for how we can capture that. So one of them is perceived stigma. So this is just the belief that people in the community hold these negative stereotypes about your group, such as being unintelligent, dangerous, violent, those sorts of things. So there's variability in this. So this is just how much you think that other people hold these negative ideas about the group that you're in. And the second type of individual response to stigma is anticipated discrimination. So this is more personal and focuses on what do you expect people, like how do you expect people to treat you in the future when you interact with your doctor, when you apply for jobs. So this is your expectancies. These are both super cognitive, as you can tell. So these are all just things people are thinking and their expectations. So there's been a ton of research in other stigmatized groups, so people with mental illness, people with HIV, people with substance use disorders, showing that if you perceive stigma, if you think the community has all these negative attitudes about your group, you're much more likely to have low self-esteem, higher depression, more unemployment, social withdrawal, risk behaviors. I mean, the research is just, there's tons of it showing that this link between perceived stigma and sort of negative outcomes, poor adjustment. But there's also a lot of research suggesting that perceived stigma is not harmful to everybody. So some of you might be in a stigmatized group, sometimes you can think that people hold negative attitudes, but it might not necessarily impact you. Like you might think that people have these negative attitudes about your group, but maybe you don't care about that, or maybe you have other ways of dealing with that. So it's not universally harmful, but what I'm investigating in this study is whether we can identify the mechanism. So it might be that people who perceive stigma and then also expect to be treated unfairly, those are the people who have negative outcomes. And so that's what we tested here. So We wanted to see whether people who perceive a lot of stigma and also expect unfair treatment in the future are the ones that have poor functioning in a variety of domains. So we looked at community adjustment, mental health symptoms, and substance-dependent symptoms, which are kind of standard outcomes for justice-involved populations. But we also looked at recidivism because there's some theory suggesting that for offenders in particular, if you kind of don't feel comfortable around the community at large, you might be more likely to hang out with the antisocial group and then engage in more criminal behavior. So we also looked at that as an outcome. So for this study, I had access to a group of 340 adult inmates in Virginia. They were all incarcerated on felony offenses. This was a semi-longitudinal design, so we had both of the stigma measures assessed just prior to getting out of jail, so within a month of them getting released. We asked them about perceived and anticipated stigma, and then we measured all the outcomes 1 year post-release. So some example measures that we used for stigma, people on the outside believe criminals are bad people. We asked people, how much do you agree with that on a Likert type scale of 1 to 5? And then anticipated discrimination, an example of that is people in the community will treat me unfairly. So just basic kind of asking people, what do you expect? What do you think will happen? And then for our outcomes, we had self-report for everything except for recidivism. We had both self-report and official records of arrest 1 year post-release. So we found that among adult jail inmates, those who perceived more stigma were more likely to expect unfair treatment right before they got released from jail, and expecting unfair treatment from the community predicted worse adjustment in the community 1 year post-release. So community adjustment was measured, it was an index of a variety of factors. Were they employed? Did they have stable housing? Did they support their kids if they were required to pay child support? Did they volunteer? So this was an index, and so people who expected more unfair treatment did worse off in that domain. So again, thinking here, this is a potential mechanism that we can target. People's expectancies are very amenable to intervention. Yeah?
So in what you asked around perceived stigma,
Mm-hmm.
give an example of the questions. How many questions, and is this a standard question that's out there that's used?
Yeah.
That, or because it's kind of subjective otherwise.
Yeah. So there's a lot of stigma measures out there that have been administered for people with mental illness and people with HIV. So there's a huge body of literature using these measures with those groups. And what we did was adapted them for offenders. And interestingly, a lot of the stereotypes actually are similar between a lot of different stigmatized groups. We added some about being dangerous and violent. So basically, we asked them, how much do you agree? How much do you think people on the outside think criminals are violent? Blah, blah, blah. So we had like 6 items about perceived stigma and 4 of anticipated discrimination, and they were both internally consistent, reliable measures. And yeah, it is all subjective, and that's the thing in stigma research. There are measures of actual rejection that people have experienced, but people's perceptions is what is most important. So let's say, for example, if you ask somebody, have you ever been rejected or have you ever been fired because of your criminal record? People might perceive that they were fired because of their criminal record. They might perceive that they were fired for another reason. So the perception is really critical here. And that really is what influences behavior. So it may or may not be actually what happened, if that makes sense. Any other thoughts about that? So you can see here, we did not predict 3 of our outcomes. Anticipated discrimination was not related to these other things. So part of what I wanted to look at is, okay, so we're not finding an effect for other outcomes. Maybe there's another mechanism here that explains this relationship. So maybe when people expect to be treated unfairly, maybe they withdraw socially from the community and avoid other people. And maybe that's what leads to some of these negative outcomes. So in the second study, it directly built off the first, just looking at another mechanism. So this model looks exactly the same. We tried our best to replicate the same exact outcomes in this study. And then we looked at social withdrawal as a mediating mechanism. So basically we said, okay, if inmates expect to be treated unfairly and they withdraw socially and avoid other people, is that what can explain poor functioning in a variety of areas post-release? So we had a separate sample of 197, all male this time, jail inmates. These were not just felony offenders. They had a mix of misdemeanor and felony, so they were arguably less severe than the first sample. And again, we had a semi-longitudinal design. We assessed stigma right before people got released. We assessed social withdrawal 3 months post-release, and then all of the other outcomes 1 year post-release. And so what we found in this study is that inmates who expected to be treated unfairly prior to release were more likely to withdraw socially 3 months post-release. And then those people had poorer mental health 1 year post-release. And this is a significant indirect effect. I left this effect on here because we did see a trending effect that they also had poorer adjustment in the community, but it wasn't quite significant. So basically what these two stigma studies are showing is that these are two potential mechanisms that we can intervene with. People's expectancies about how they're going to be treated, and then their behaviors. So whether would they withdraw socially and avoid community members and institutions. And I'll talk about some of that later and how we want to try to intervene with that. Okay, so the last part that I'll tell you about is what can we do to adapt some of our existing mental health treatments for people in the justice system. So the first study I'll tell you about is a pilot study of a brief dialectical behavior therapy skills group. Has anyone done DBT? Known DBT? Familiar with DBT? No? Okay. So here we're moving back a step. We're talking about when people are serving their sentence. So we're not talking about reentry anymore. We're talking about when they're actually incarcerated. Okay, so dialectical behavior therapy. So you might be interested in this if you work with people with borderline personality disorder, if you encounter them, because this is a highly evidence-based treatment for this population. It's one of the most effective treatments for personality disorders in general. We don't have a ton of treatments that really work for that population, but this is one of them. So DBT is typically a really intensive year-long treatment where people have an individual therapist. They go to 6 months of skills group where they're learning behavioral skills. They have the ability to call their therapist at any time and receive coaching. So this is a standard treatment model for borderline personality disorder. And it's, not surprisingly, it's only really been implemented for really severe personality disordered populations with high rates of self-harm or suicidal behavior. It's been implemented in forensic settings, for instance, with offenders who have personality psychopathology or self-harm or other harm behaviors. However, a lot of the DBT skills, like the skills component of this intervention where you're teaching people how to regulate their emotions, you're teaching them mindfulness, you're teaching them how to interact with other human beings in an effective way without hurting someone or hurting themselves. Those core behavioral skills actually broadly apply to a lot of different psychopathology, and there's been more and more evidence that DBT skills can be a standalone intervention that are kind of transdiagnostic, so they can be applied to a lot of different types of psychopathology. So what I wanted to see is, okay, people who end up in jail, who a lot of them have substance use problems, a lot of them probably have poor emotion identification, regulation. Can we apply some of these DBT skills to this population who could probably benefit from them? Because most people can benefit from DBT skills, even those who don't have psychopathology. Can we try to apply the skills group to this population and see if we can improve their behavior? So that's what this study tried to do. So, however, there are a lot of barriers to implementing evidence-based treatments inside the criminal justice system. So treatments like DBT or even treatments like cognitive behavioral therapy are often considered too long to implement in the justice system or too intensive. So when people get incarcerated, they can get released in a day, they can get released in a couple weeks, they can go out on bond, they can get out on good behavior. There's a lot of movement, and you don't always know how long someone's sentence is, so it's really hard to predict what dose of treatment someone's going to get because you don't know how long they're going to be there. So it can be really hard to implement evidence-based treatments for that reason. And also in jails in particular, not necessarily prisons, they don't have mental health staff. So does that surprise? I don't know. This shocked me when I first started working in jails and prisons. They have maybe one psychiatrist for the whole jail who's on call for every single person who needs mental health treatment, and we know at least 60% of them do. So that's a lot, and they often don't have a psychologist there. Maybe if they have, they might have one, but they're certainly not doing CBT or DBT. They're doing crisis management and dealing with emergencies and suicidal behavior and self-harm. So there's not a lot of resources. Jails just don't have the resources to pay people to work there, to do these sorts of things. And then a lot of people don't want to work there either, so there's that. So jails there's lots of barriers to implementing the types of treatments we know work in these settings. So what I tried to do, though, is try to, with knowing these barriers, try to shorten this intervention and adapt it for this setting. So DBT skills are typically 6 months long of weekly group treatment. So I took that 24-session intervention and picked out 8 different skills, basically, that I thought were super helpful for people who are impulsive or use substances or have trouble regulating emotions or who are aggressive, and shortened it down to an 8-session intervention. And pilot tested that with 2 cohorts of adult male jail inmates. So we had 10 people only. It was a very small study. Did this when I was in grad school. Myself and another grad student who were trained in DBT delivered the intervention. And we assessed people's coping skills before and after the intervention just to see if we can find any sort of movement here. Can we improve people's coping skills, even the smallest, if we give them this kind of watered down DBT skills intervention? So we assessed their general DBT skills use, we assessed general dysfunctional coping, and then their tendency to not accept responsibility for their behavior and to blame others. So we assessed those 3 things before and after the intervention. So since I don't think anyone here is a DBT person or kind of uses these things, but basically these are the types of skills we targeted in our intervention. We taught them, so these are all adult male jail inmates. So we taught them mindfulness. So basically we taught them that when you make decisions in emotion mind, sometimes those decisions aren't the best ones, and we should try to get into a reasonable mind or a wise mind before making decisions. So we tried to teach people to build some space between their emotions or their thoughts and their actions with mindfulness. We helped clarify their values. So what's important to you? What do you care about? And you might be surprised by this. Their values are pretty consistent with my values or other people's values that I know. They want to be a good parent to their son or daughter. They want to be a better husband. They want to be financially stable. They don't want to be homeless. So we tried to clarify what their values are to try to get them to identify what their target behaviors were going to be throughout the intervention. We taught them distress tolerance, which is basically really basic, useful skills to get through an emotional crisis. So if you guys think of the last time you were experiencing an emotional crisis, you can kind of think about that. We taught them how to kind of get through that without doing something you're going to regret. So, okay, you're really, really angry, you're experiencing rage. Don't hit this correctional officer, because then you're going to get whatever amount of time added to your sentence, and no one wants that. So we taught them distress tolerance, which is actually pretty difficult in a jail setting, because in typical DBT, you teach people distress tolerance, but you get to use a lot of things to help you. You get to have access to things like ice, that you can actually put ice onto your body to lower your physiological and emotional arousal. In jail, you can't just get access to ice. They don't give you ice in jail. They don't care about that. So we had to get really creative with thinking how to teach people to tolerate distress without doing something they would regret. We taught them emotion regulation, so how to increase positive emotions and decrease negative ones, both in the short term and the long term. And then interpersonal effectiveness, so how to engage with other human beings in a way that you're not hurting them, you're not getting hurt, you're getting what you want, they're getting what they want. Basic sorts of emotion or interpersonal skills. These are just the specific ones, but if no one's a DBT person, things like please master won't really make sense. So what we found, and again, this is only 10 people, we did find a significant decrease in blaming others. So we found that people were more likely to take responsibility for their behavior after this intervention, which is critical for antisocial behavior and crime. So we're really encouraged by this. We also found that they were more likely to report using skills, but it wasn't significant. I mean, we only had 10 people, so we wouldn't expect a ton of statistical significance here, but these results are really encouraging to us. Like, we can sort of shift people's coping in a way that's helpful with just a very brief intervention. All right, any thoughts about that one? Or okay. Anyone want to work with, anyone want to learn DBT now? Or yeah.
Wouldn't the DBT be effective because the people are in a prisoner interacting with other antisocial people after DBT and throughout their daily life, they're interacting with more like antisocial people in general? So wouldn't that lessen the effect of DBT?
I don't think, not necessarily. So I will say, like, in a jail setting, you find a good mix of, like, okay, this person's addicted to crack, this person's like was prostituting. You find a good mix of people with, they're not necessarily like all antisocial personality disorders types of people, and yeah, they interact with antisocial people, especially in the jail, but it's not exclusively that. So like a lot of the skills they practiced in the DBT group were, okay, you have a call with your son's mother tomorrow and you really want to see your son, and yet you've done something that led you to get in jail. How are we going to have that phone call in a helpful way? So, I mean, I don't think interacting with antisocial people necessarily reduces the effectiveness. We did actually have a psychopath in one of our groups, though, who really derailed our group because we can talk about psychopaths another time too, but they like learning about interpersonal skills because then they can use them to get what they want out of people. So that's a whole other thing, but that's not, I mean, you can encounter those guys anywhere, not just in the jails. Most people in jail are not psychopaths. Okay, so let me see if we're good on time. The last study that I'll tell you guys about is one that I did when I was doing my postdoctoral fellowship at Yale. In Connecticut, there's a lot of work right now around trying to get medication-assisted treatments into the criminal justice system. So I'll talk about a pilot study that I was a part of during postdoc. So probably don't have to convince this group, opioid use is a significant public health problem in the past 10 years. It's actually higher among people in the justice system. You see much higher rates of opioid use in the criminal justice system than you do in the general population. So these people often wind up getting incarcerated. And people in the justice system who use opioids are at particularly increased risk, because if you get incarcerated, so let's say you're using opioids, you're using heroin, whatever it is, Oxycontin, before you go in, get incarcerated. When you're incarcerated, you withdraw from those opioids, and then your tolerance to that substance decreases. So when you get out, let's say you want to go back and use heroin, your risk of fatal overdose is insane in the 2 weeks after you get out of jail. So we're seeing that a lot of people are dying by overdose when they get released who were on opioids previously. So medication-assisted treatment, so including methadone, buprenorphine, naltrexone, these are all evidence-based treatments for opioid use. However, what we see is that, so they're all evidence-based treatments for opioid use, and a lot of times people are on those in the community. So they might be receiving methadone, and then maybe they did something illegal and got incarcerated. They go through the same period of withdrawal from that medication-assisted treatment when they're incarcerated. So they withdraw from methadone or buprenorphine or whatever they were on. And has anyone dealt with people who've gone through opioid withdrawal or methadone withdrawal in particular? Okay, so there's research, and I've had some experience too working with these people, that it's incredibly aversive, worse than opioids, a lot of physiological aversive physiological symptoms. So research shows that people who go through methadone withdrawal will never go on it again, like not open to medication-assisted treatment after that point. So this is a problem from a harm reduction standpoint. If we're thinking about offering medication-assisted treatment to keep people off heroin, we need to find ways to keep them engaged with this. So offering it during incarceration is one of those ways, but federal regulations restrict where you can offer methadone and how you can offer it. So in Connecticut, what they did, some of the correctional facilities there got licensed to be able to offer methadone in their facility. And they brought in community methadone treatment providers who were able to dose people while they were incarcerated so that they didn't have to go through methadone withdrawal. And so what we wanted to see is, Okay, so people who are continued on methadone, does that improve any of their behavior during incarceration? Does it make them less likely to, recidivate? Does it make them more likely to engage in methadone treatment when they get out? So we had access, we did this evaluation after the fact, after it had already been done. So we had 203 inmates who were maintained on methadone during incarceration for their entire incarceration, compared to 198 who went through forced withdrawal from methadone upon incarceration. So we compared those groups on a variety of outcomes. So these are just a couple of the findings. What we found is that people who were continued on methadone during incarceration had significantly fewer disciplinary infractions during incarceration, so they got in trouble less often when they were there. And they were also significantly more likely to re-engage in methadone treatment once they got out. So within 30 days, 40%, I see my thing got messed up there. So they were more likely to re-engage with methadone 30 days post-release as well as 180 days. So we found mixed findings for recidivism. We didn't initially find any difference there, but we did find that people who were continued on methadone with the same provider before, during, and after incarceration were less likely to recidivate. So these are encouraging findings, suggesting that if we can continue people on these sorts of medication-assisted treatments during their period of incarceration, we might be able to improve their behavior and keep them from having fatal overdose in the weeks after release. And we didn't have overdose data for the study, but that's kind of next up, is looking at that. Okay, so briefly, I'll just tell you guys about what I'm most interested in doing right now. So I'm really interested in stigma. That's kind of like, that's been my thing for a while, and I'm still interested in that. So we've seen, like I showed you today, stigma impacts people with a criminal record in terms of their community adjustment. But it also, from research with other stigmatized groups, it affects treatment engagement. So among people with mental illness, people with HIV and other diseases, if they perceive a lot of stigma and expect their provider or their doctor to have these attitudes, they are much less likely to engage and adhere to treatment. Much less likely. So they're more likely to drop out, more likely to not take their HIV meds, less likely to be adherent with their psychiatric meds. So these perceptions and these expectations are critical for treatment engagement, and we've never looked at that in the justice system. We don't know if people in the justice system, if stigma is related to their engagement in substance use treatment, for example. So that's what I'm interested in doing, and I'm collecting some data on that at Yale, and then also at the Day Reporting Center, hopefully if I get IRB approval here in Johnson City, looking at the relationship between stigma and engagement and treatment to try to see if we can pinpoint that relationship. And then the idea in the future is to I'm developing an intervention to target stigma in this population, but that's sort of way off in the future. So thanks to everyone who helped with all of this research and the funders. And if anyone has questions or comments, I'm happy to talk more about it. Yeah.
So one of the things I think about stigma portion we talked about, you used as a measure of mental health symptoms is what you looked at as being sort of the category.
Yeah.
And you used personality inventory for this.
Mm-hmm.
So we're not really talking about disorders, we're talking about symptoms.
Yeah.
So what amount of symptoms and how did you use that personality inventory as a way to really?
Yeah, so this was less than ideal. We only had access to the PAI, the Personality Assessment Inventory, for the outcomes. So that has a depression and an anxiety scale, so basically like an internalizing scale. So it gets at symptomatology there, and you have to score you have to have a certain elevated score on that to say you have significant depression, anxiety. So we really only were capturing depression, anxiety, not specific disorders or other types of issues there. So that is definitely a weakness. Yeah.
I work in HIV psychiatry and had a lot of experience with HIV/AIDS stigma.
Yeah.
And you mentioned it as a resource for a lot of questionnaire development on stigma. And thinking about the overlap that with mental health disorder, it seems like the time point that you're interested in investigating about the point that people are released from incarceration is critical. And research in HIV shows that people who are HIV negative released from prison, their highest potential risk for HIV is right at the time, shortly after release.
Mhm.
And mental health use, I think, is an important issue here, because with psychiatric disorder at the time of release, too, that's a really important issue in terms of exposure to stigma.
Mhm.
And so one thought is that what about trying to join the foci of HIV prevention with stigma reduction for people in general on release? It's important, but specifically for those who have psychiatric disorder and might be exposed to HIV, it's critically important, I think,
Mhm.
to look at what you would do to intervene on both at the same time, and thinking about intervening on stigma, that stigma can actually produce the mental health symptoms rather than just be epiphenomena
Mhm.
of mental health symptoms.
Yeah.
I think is really important. It seems
Mhm.
like there's so much more research on what's characteristic of stigma and a lot less about stigma intervention.
Yeah. There actually is a lot of stigma intervention stuff, but not with people with a criminal record. There's some with people with HIV and lots of people with mental illness. So there's lots of different stigma interventions out there. I think especially when you're looking at justice system, you've got to adapt anything to like fit this system in particular. But yeah, I think there's a big need for that sort of work, because we know that from other work with other stigmatized groups, we can intervene with these attitudes and expectancies and actually produce positive change. But yeah, I think what you're saying about targeting kind of HIV, psychiatric conditions, criminal record, that's a great idea. That should be the next grant. Someone will fund it. So, yeah.
And I think also just to highlight the point of, release from incarceration, the general population undergoing release should be a target for prevention of both psychiatric disorder and HIV.
Mhm.
Not just targeting the subgroup that we know are most concerned about, those with known psychiatric disorder.
Yeah.
And that I think is hardly paid attention to, but really deserves more attention.
Yeah, I think so. Thanks. Any other thoughts?
Thank you.
Thanks. No problem. Yeah.